to be working.
Right, did you do anything at the back? Mandy, did you? No. Okay, good. So I hope you're all kind of a bit into the mood. So the afternoon session is basically just to encourage you talking to each other, okay? I've labeled it thinking statistically, but it's actually going to be more of an exercise whereby we're going to look at scenarios, we're going to discuss them, and I'm going to put you into the respective groups. I want you to come up with there's a research question. I want you to think about the elements of it and discuss about it. And then when the different groups sit down and present, then we at the back can be giving input into each group's presentation, which will be different designs, okay? And hopefully by doing that, we're going to see where the gaps, and we can have input on how else could have been improved. And then I think that will also be useful when you think about your protocols and your presentation for tomorrow, okay? So just to give you a bit of context, this is just to say that obviously science is built upon observation. So it's an Italian proverb. Basically what we do in science is observe, okay? So it's the power of observation that leads us into research. And again, you've seen this before from your first workshop, but just to kind of a very easy light note reminder in terms of the research process. Obviously, it starts with you having a question in mind, okay? Then you have that questions, and then you think, okay, well, I have this question, then I think, how best can I answer this question? Which takes you into thinking about what's the best design to answer that particular question as a second step. And then after that, you think, okay, then I've got the question, I've got the design, and then I need to recruit people, I need to get data, because it's data that gives you the evidence. So that becomes your next step. And then you have data, then you think of analysis. How best can I analyze this particular data set? And then, of course, interpretation. And then, if you're lucky, publication, which we all love, all right? So that's just a reminder. But obviously, this is just a note, so that things can go wrong in this particular process at any point. From the question itself, how we ask the question, the design elements, the data that you've collected, how you collect it, analysis, and how you interpret it, okay? So just to be aware of that. So this just say what are the aims of research? Obviously, we have different types of research, clinical, could be epidemiological, amongst others. We're not looking at quantifying things. So we're going to look at the prevalence of something. What's the prevalence of Ebola in a particular country A? Okay, so you want to quantify that. So that's just a way of trying to see how much disease there is in a particular community or geographic location of interest. All right? And sometimes you obviously want to make comparisons. So you want to compare prevalences between country A, Ghana, and Ivory Coast, for example. So we make comparisons. It could be interventions, which is pretty much the context we've been talking about since this morning, where you have a drug, and you have people that give the new treatment and people who don't get the new treatment. And then you want to see whether the differences you get between these two groups are due to the new treatment that you've introduced. And other types of studies, obviously, prediction studies. So we talk about prognosis. So I want to be able to look at you as you go to your clinic, and given certain parameters, which is your age, your gender, your socioeconomic status, and everything else, I can be able to give an index, a probability of you getting an outcome. That outcome could be, for example, could be Ebola, for example. So you can look at which age group is it, which area are you from, what's the socioeconomic status, what is your previous exposure, and those elements, you can put them up into a model, and they can give you an index or a probability that this person is likely to have Ebola. So we use that for clinical management in a lot of the time, whereby you look at patients and you can put in their characteristics and have an index. So you can then use that index to make decisions on whether these people should be given some sort of intervention or not. This is quite helpful in situations whereby, obviously, we don't have all the money in the world, all right? And we can't intervene, we can't introduce interventions to everybody in the population. So therefore, you may think that you need a system whereby you can identify your high-risk group. And it's the high-risk group that you want to be able to be aware and be able to give the intervention. And then obviously you have association studies, or sometimes you just want to explore etiology, okay? That brings you to the main elements. Obviously we talk about the questions. And then the research design itself, where we have to think about who to study. That's usually the first question, who to study. And that's very key. Because if you get the target population wrong, then everything else, it may invalidate your question. So you may have a very good question, But if it's applied to the wrong population, then it just invalidates the whole research. Then what to measure and when? And I'm going to come back to this because I think a lot of the time we as clinicians, we as researchers, always concentrate about the question and very less so about what we're measuring. How do we measure it? And sometimes I sit down and think about what don't we know about research? There's so much stuff that's been done about your areas of interest. So if you think about malaria, if you think about HIV, there's tons and tons of papers that people have done research, but they're all different. They're all different, and everybody's always been pointing about the limitations. But it's because I think sometimes you actually don't think about measurement, because measurement, everything else is hinged upon the measurement. So if you're measuring somebody's blood pressure, it is important that that is measured as accurately as possible, and that is standardized, because then if you measure blood pressure without the precision it requires, then you may end up getting unrealistic results. The tool that is used to measure blood pressure could also be different, and that could also account for the differences we see in the different studies. So you have a different machine of blood pressure which is used in a particular hospital, you go to another hospital, a different machine. Those machines actually are measuring differently. So the variability you see between these studies is just because of you're using different machines. But a lot of the time people don't actually sit down and think about this, I want to call them trivial, but they're not trivial. But I think as scientists, we tend to focus more much about the question and forget the core elements, which are the nitty-gritties that we should be concentrating on. And then, of course, you think about the interventions, which come from your questions that you already sat down to think about. And then, obviously, from a statistical perspective, is having a large sample size. So, obviously, everything else is hinged upon having the right question and having a good amount of data that enables you to be able to answer that question with some certainty. Okay. So if you had a good question and then do not have enough sample size, which means you have low power, which means that it's very easy, you may end up reaching a wrong conclusion. Why? Well, all of us love p-values, which is unfortunate. It's because you say, oh, that's non-significant. Because it's non-significant, it's highly likely it's going to be published, and it may actually lead you to conclude actually there's no difference between A and B. But that may not be true. It could be that there is a difference, but you do not have enough power to see that difference. Okay, so these are different elements. So people don't think about this sometimes, because it could be like, oh, this study just shows there is no association between this and this. But that's not exact. That may not be intrinsically true, because it could be that study actually was not powered enough to see that difference. Okay, so these are different elements that we have to be thinking about. So obviously, there's an array of difficult decisions we have to do, and hence the reason why we are here. We said that we need a protocol. Okay, what does the protocol do? The protocol enables us to think about all these issues in advance. Okay, the clinical trial system whereby you have to have a protocol where you specifically specify what you're going to do, what is the question, what is your analysis plan, how is it going to be analyzed. It's just to make sure that people don't start shifting goalposts. Okay, you look at the data and then you suddenly think this primary question is not statistically significant, so I'm going to change it to something else based on what the data is telling me. Okay, so the protocol enables you to actually sit down and think critically. This is my questions, this is my population, this is the measurement, this is how I'm going to analyze it, and this is how I'm going to interpret it. So it kind of allows you an opportunity to actually think of these things ahead of time, and that's very important. And hence the reason why we are trying to preach this to you, in so many different ways, such that you be thinking about this. It's about the question, and I think when you've gone through this process, I always tell people, the rest of the stuff is always easy. Okay? We as statisticians, unfortunately, do 80% of our work is to do with the boring work of data cleaning and data management. Okay? An analysis is always very straightforward. If you have a clear design, a clear questions, and well conducted. An analysis is always one line of code. One line of code. That's all it takes for the analysis. But why do we spend so much time with data? Because people never thought about certain things carefully. So we end up doing a lot of data management, manipulations, and if you have missing data, then you have to think about very complex statistical ways of correcting that, like multiple imputation, because you're thinking now we have so much missing data that may affect the robustness of the results. So we think of complex ways of trying to correct that. But if that data was carefully collected, we wouldn't have to do that. Okay? So the analysis is always very straightforward. I think it's just because people don't take so much time thinking about the elements, the building blocks. That's why it takes time. Okay? So we hope that we're going to be making you thinking about these things early in advance. Early in advance. Okay? That's why a protocol is very, very crucial. I said I'm going to come back to this because I was involved in a project which was an international project across 8 different countries. So I kind of did work in maternal and child health. And, so let's think about measuring heads. Right? We are several in this room. We all have different head sizes. Okay? So we can measure that in different ways. And then we can classify what we think is a big head, what is a small head. Okay? What is a big head and a small head is depending on what measurement we are using. Okay? So I can come and use a tape measure, which is quite a simple way of doing it. I just put a tape measure around your head and I get a measurement. But how I place the measurement, or where on the head I place it, may make a difference on what that measurement is. Okay? So alone, before you even think about the question, that can actually be the difference in whatever you see. All right? It is difficult to think of anything in medicine that does not directly or indirectly depend on counting or measurement. Because everything we do, you have the question, you have to measure something. You have to measure something. You as doctors, you're constantly measuring things. But how much time do you actually dedicate to measurement? Probably very little. So this is something that I'm just trying to say that you have to be thinking about, because measurement error alone, if you measurement error, in each measurement, each data point you have in your data, the amount of measurement error that is in it affects the overall result. It affects the precision of the overall result. Okay? So that's important, because at the end, you're going to make decisions based on those measurements. It's a data point. All right? But if I measure your head and say it is 35 centimeters, and when it's 35 centimeters, the error around that 35 centimeters is 5 centimeters. That's a big error, you'd think. Okay? So that is the effect. And then you multiply that by 1,000 people. So you can see how much off you are in terms of the actual measurement. And then we're going to use this distribution and apply it to the population. And use it for a screening test for the population. You can see where I'm going with this. All right? So you have a very incorrectly measured, not very well validated, and then you're applying to the general population to classify people who you think you should be capturing as your high-risk patients, and then intervening. Okay? So it has implications. So your false positive rates may go high or low, depending on what cutoff you've chosen. And this is just, I don't need to go through that, just to say, what are some of the things that actually affect your measurement? Quantity being measured varies. Blood pressure, and you take a blood pressure measurement, that depends on whether I've just come from the gym or not. Okay? If you just take my blood pressure after I've been to the gym, obviously that would be different to when I'm just resting and watching television. Okay? The operator, which is the key thing, the people who are taking measurements. Most of the time we don't think about people who are taking measurements, in the sense that, in a clinical situation, you have several doctors, you have several nurses, everybody's measuring. You come, you measure, you come, you measure, you come, you measure. So there's a lot of variability in terms of how people measure. There are people, if you're measuring your head, even if you do it now, there are people who will make it tighter, there are people who make it looser, and there are people just going to be random. All right? But that introduces some sort of bias that we don't think about. And because we don't take time to try and standardize everybody in how to take the measurement, such that we know that people are taking it systematically in the same way, such that if there's an error, it's all kind of systematic, which is not a problem, because then we can always correct for that. Okay? And then obviously that depends on the skills, the equipment you're using, among other things. So here's the exercise. First, I'll give you a context. We're going to do an exercise on Zika virus and microcephaly. So this is quite recent. Everybody's heard about Zika? Yes? Yes. Microcephaly? Right? So this is going to be a demonstration of an emerging situation, which obviously was declared by the WHO, feasibility of how best can we do this study, and causality. Can we actually create a linkage that Zika virus is responsible for, Zika virus causes microcephaly, and that may lead to future neurological sequelae or neurological issues. Okay? The good thing is, to date, there's no clinical trials being done on this. So we're moving away totally from clinical trials. We went to observational study. A lot of stuff has been done on this, but there's no clinical trials yet. So there'll be no adaptation this afternoon, I'm afraid. So this is just to give you a context. So Zika virus first discovered in Uganda, correct me if I'm wrong, I'm not a clinician, I'm a statistician, all right? 1948, interesting. This thing has been there, it's not new. We just didn't do much about it. Transmitted by mosquito, we know that dengue-like fever illness associated with neurological symptoms. You see how the world was in disarray when, the people I know who never went to Rio Olympics, they never went to Rio just because they were thinking of getting pregnant in the next 2 years. So they couldn't take the risk. These are the implications of it. So the recent spread of the virus since 2010 reported caused outbreaks in several islands in the Pacific. And that is why the whole world was concerned about it. And obviously the fact that the world has become a global village is then you have an event like Rio Olympics, the whole world converges in Brazil, you get Zika and you transport it everywhere in the world. So it affects the whole human race. So also identified in several African and Asian countries, it's obviously spreading. So it's not just an African problem, it's everybody's problem. And then obviously the major outbreak happened in Brazil and in Latin America in 2015. Okay? So, I'm not supposed to be there. Also say the WHO then declared that as an international health emergency because of its link to having neurological defects in newborns, which is called microcephaly, right? During pregnancy. So before 2015, almost nothing was known or reported about Zika virus and the consequences of infection during pregnancy on central nervous system. So you can see, even though we've seen that thing before, but nobody ever, because it probably started, killed a few people, then died, started, killed a few people, then died, so it wasn't a concern. So by the time it's actually coming as an outbreak, we actually know nothing about it. So people are now trying to, where do we start from? If you do this is a quick literature study that was done in PubMed or whatever. You look at the literature, 50 articles on Zika from 1948 to 2010, right? I'm sure if you hit malaria in the last 6 months, you'll find over 100 articles, okay? That's because everybody's talking about it. There's been one report of central nervous system infection in mice, so animal studies as well, which helped us to kind of build the evidence. 13 cases reported until 2007. 70 articles between 2010 and 2015. 10 of those with just, if you put keywords, neurologic, nervous, microcephaly, and the Killian syndrome. 1,000 articles since January 2016, half of those with those keywords, okay? This is because of the outbreak, so everybody's panicking, there's a lot of scientists, I tell you, when this happened, they just left whatever they were doing. This is where the money is, Zika. Everybody went Zika in various aspects. So it's just like everybody else was concerned about it. So you have people looking at it from different angles. You have epidemiologists, you have clinical scientists, neurologists, and people were dealing with animal models because everybody was concerned about it. There was emergency funds set up to try and solve this. So the question is, or the task is, quite simple. Here's the question. Is Zika virus infection of the mother during pregnancy causing neurological defects in newborn babies? So that's the question you're trying to answer, okay? That is the question. The hope is that this example will provide an insight of epidemiological research on causality, but there's not been any clinical trial done, progressing in an emergency context. So think about an outbreak situation, but we're now looking at an outbreak, observational study context. So what are the processes? What are the types of studies we can think of that can answer the questions? What are the constraints? And how can we progress that research from observational studies or towards other observational studies that gives us stronger evidence? All right? So the group exercise is, you mighty people are the country representatives on emerging infections in global health. You've been asked to design a study to help understand whether there is an association or there are causal pathway or link between Zika virus during pregnancy and neurological defects among newborns. All right, that's pretty much, you've been tasked with this in your own country. Luckily enough, we are all in those groups already. I just want you to spend about 45 minutes, discuss this within your group, how are you going to go about it? The potential limitations of the chosen design, which is an observational study, okay? And also put your country-specific context when you're thinking about this. The challenges you might face in answering this question. And then what I would like is each group to prepare a 15 minutes presentation about how they went about this. And then the group is going to present. Hopefully if you can do it on PowerPoint, that would be good. And then we're going to have questions from everyone towards their questions and their thinking. And then I hope from that we can actually have a learning experience from that. The good thing is, see icing on the cake, is every group is doing a different design. So, you're 4. So I decided the Ivory Coast, they're going to think of a case control study. The Uganda team, a randomized control trial, even though none has been done in this area. Okay? So I just want you to think, like, if you're to do a clinical trial, how would you go about it? Ethiopia, a cohort study. And Group Ghana, a case series study. Okay? The idea is, at the end of the day, we have exposure to all the different ways we could answer these questions. And then we can have discussions about where are the limitations, where is the level of evidence. Okay? And let's see what are the limitations you guys faced. And hopefully that's going to bring everything together when you think about your research questions, your protocols tomorrow, and your online modules. Is that all very clear? So, to make your life a little bit easier, I have just bullet points on what things I would like you to be thinking of. Plus, obviously, you can add your own. First of all, is think about the purpose. What do you want to learn from these questions? What's the question? What are we interested in? Think about the question. Second, target population. So you can take a copy of this slide, make a photo of it, because some of you will probably go in the next room. So think about the target population. So these are the elements I would like to see in your presentations. Target population, define it. Obviously, when you're doing research, you talk about a sample. Okay? So that sample has to be defined. Selecting your participants. Most importantly is the case definition. All right? How do you define a case? What's the case definition? What's the question? What's the case definition? I want you to be able to think about that. Inclusion criteria, exclusion criteria. Can we define and measure all that needs to be defined and measured in that particular study? And obviously, that's just a note to say the degree of selectivity affects inferences about the population. So, are we able to generalize from this? Okay? And even more, the recruitment processes. So this is just like, give me some ideas of what you're thinking within the context of the different designs you've been given. So what information has been collected? How quickly is it needed? It's an emergency situation. We need to collect this information fast. So you can be pragmatic about it. It doesn't have to be perfect. If it's an emergency, you may have to, sacrifice other things, a trade-off. How will you act on the results? And then, I'd like to hear about a slide on analytical considerations, at how you think this data can be analyzed. Because that will help us understand where you are at and how we can be able to have input. Obviously, things like sample size. Some of the limitations of the study, the level of evidence you think your study is able to provide, and just some recommendations or conclusions. Okay? Any questions? Yeah? Right. So, we had 2 groups here. So the 2 groups that were here, can I kindly move to the next room? Does that make sense? There were 2 groups that remained here. So those 2 groups can now have it's very nice, the other rooms actually. They have like a...
Ethiopia and Ghana are moving to the next room.
Yeah, Ethiopia and Ghana to move to the next room, and then the other 2 remain here. So if you just, within your group, think of, can you select somebody who is going to obviously prepare something, or is going to present? So as you discuss, make those points, and then, how are we time-wise? What time should we come back?
It's 3:20 now.
Okay. So should we come up? Do we have a break? Is there a break?
Also, if anyone wants, you can just get coffee. It'll be ready in 15 minutes, so if you want to grab a coffee while you're working,
Okay.
that's fine. The coffee will be in the same place.
Okay.
And then it's up to you to have the...
So we're going until...
Well, I've got it scheduled until 5:30.
Okay, so I was thinking if we do up to... So each group should present no more than, not more than 15 minutes. So that's at least now if we stretch it too much. So if we come back at 4,
30.
4:30. Yeah, 4:30.
I was hoping that we'll probably not go until 5:30, but if you are,
You probably need an hour. Though.
sorry?
I think an
Yes,
hour.
An hour is fine. So we come back here 4:30,
Mm.
okay? 4:30, and then should we make it 4:15? Because I'm thinking then,
So they have an hour to
is it an hour from now? Okay, 4:30. Okay, 4:30. Yeah?
Mm.
And then every group is going to have no more than 15 minutes presentation, and then we're going to contribute, and hopefully everybody's going to contribute. Okay? All right, thank you. Sorry? The next slide. The first one. Oh, the question. That one. Huh? You can, I'm happy to share it. It's just going to go around everyone. Is there any? Are you guys? Yeah. You can take it on a pen drive if you want, yeah. Has everybody got this already?
Did I just stop the recording?
Oh,
I'll leave this on, but I just want to stop the.
yeah.